Welcome once again to Fundamentals of Electrocardiography. These series of lectures are sponsored by Cardioscan and endorsed by the Asian Pacific Heart Rhythm Society, APHRS, and I'd like to thank them for all the effort they have put into arranging these webinars. Today's topic is the weird, wonderful world of Wenckebach. Those who report ECGs are familiar with Wenckebach sequences at the AV node. What they may not be familiar with is that Wenckebach periodicity is a feature of all conducting myocardial cells and therefore can occur at any level in the heart, thus producing weird, wonderful ECG appearances. So let us now explore this world and learn how to identify the footprints of Wenckebach. If you have any questions about this topic, please enter them into the chat box during the presentation, and I will aim to address them at the end. The presentation will also be loaded onto the Cardioscan website under the Education section and available for watching at your leisure. Karel Frederick Wenckebach was born in The Hague, Netherlands. He finished his MD degree in 1888 and went into private practice and was always interested in heart rhythm irregularities. In 1898, he saw a patient in her early 40s with an irregular pulse. Of course, he did not have an ECG, as this was not introduced into practice until at least 1901. Using the radial pulse and a tuning fork, he was able to sequence out the sequences with pauses, and he called these Luciana's periods. What he noted was that the interval in the pulse was longest immediately after the pause and was shortest immediately before the pause. Later on, he worked out the relationship between atrial and ventricular contractions, and he used a smoke drum, as you can see here. There was the carotid pulse and the jugular pulse documented on the smoke drum. And looking at the jugular pulse, we can see the two waves, the A and the C wave. The A is the venous and C is the arterial. And with each beat, you can see an increasing distance between the A and the C, between atrial contraction and ventricular contraction, and then there was a pause. He called this type 1, or we should now call this type 1, and this is Wenckebach second degree AV block. In 1906, Hay described type 2 second degree AV block, and then in 1924, using the electrocardiograph, Mobitz classified these ECGs into type 1 and type 2, and he was able to clinically determine the significance of each. So let us now look at the ECG footprints of a Wenckebach AV sequence. Here we have an electrocardiograph with the red highlight showing the sequence. There is progressive prolongation of the PR interval, which I call AV node fatigue. First one is 210, the second is 360, and the third one is 540 milliseconds. A gradual increase, and then there is a non-conducted P wave or drop beat, and the sequence starts again with the PR interval at 210. Now, what is important in this is that there is a greatest increase in the PR interval, typically between the first and second beat, with the incremental increase of each conducted beat becoming shorter. Now, this is particularly important for Wenckebach sequences outside the AV node, although is not particularly important with AV Wenckebach. But here we can see that between the first and the second beat, 210 and 380 milliseconds, there's a difference of 170 milliseconds, an incremental increase. The second and third, the incremental increase is only 160, and this would continue to get less and less until the drop beat. So what we see then on the RR intervals is that they progressively shorten with each beat of the sequence. So remember now, AV Wenckebach, RR shortening. Again, this is what Wenckebach saw with Luciani's periods. Now, there is another important feature of Wenckebach AV sequences which is relevant to when we see it most on Holter monitoring, and this is the absolute defining footprints. What do I mean by that? Well, this is what we see on Holter monitors that tell us it's Wenckebach. And these are, the PR interval is longest immediately before the drop beat, the non-conductive P wave, and then the PR interval is shortest immediately after the drop beat. So we see these features very commonly on Holter monitor, and that's how we make the diagnosis. Wenckebach AV block also occurs in sequences. Here we can see 4 P waves, and then there are 3 R waves. And we therefore call this a 4-to-3 sequence. In the same Holter monitor, a little later, we can now see 3-to-2 Wenckebach sequence. And then we can see 2-to-1, which is very important because this is where a lot of the confusion between type 1 and type 2 occurs, and I will discuss this a little later. What about the clinical spectrum? Wenckebach AV block generally occurs in the younger patients overnight and is physiologic. This is by far the most common reason for seeing Wenckebach on a Holter monitor. Older patients, it can occur at any time, and this is pathologic. So let us have a look at the young patient. During the day, a normal PR interval. Then at night, we can see Wenckebach sequences, and again, we look for the absolute criteria. This is due to heightened vagal tone. Such appearances are very common, as I said, and they may just have one drop beat during the whole 24 hours. And you can see here the absolute criteria are fulfilled and there's just one dropped beat. In the older patient, Wenckebach can occur at any time. And during the rest of the time is usually first-degree AV block. As well as this, there may be other features of conduction tissue disease, such as a bundle branch block. Let us look now at the electrophysiology. Firstly, the narrow QRS. A Wenckebach second-degree AV block with a narrow QRS is AV nodal. Its incidence is about 4 to 6% with Holter monitors. It's rarely symptomatic. It's reversed with exercise and atropine, and occasionally it's intrahisian. And in this situation, exercise, and in particular atropine, may make it worse. Let me show you a symptomatic case here of a rate of approximately 40 beats per minute sinus rhythm, and there is here the absolute criteria shown and a 2.4 second pause. Now let us have a look at the electrophysiology of a wide QRS. This suggests disease, but remember, many of them, if not most of them, may occur still at the AV node. However, there is a group where it's either intrahischian or distal and suggests significant conduction tissue disease. Here is such an example. We can see that the Wenckebach AV sequence is occurring with bundle branch block. You can see the absolute criteria, but what is important now is that there is also first degree block, so that the first beat after the drop beat has first degree AV block at 280 milliseconds. This suggests that there is distal conduction tissue disease, and such patients are usually clinically have symptoms, and for that reason often end up with a cardiac pacemaker. Now I'd like to briefly discuss Mobert's type 2 second degree AV block. Now this is very confusing because it is often 2-to-1 AV block, and we've already shown that Mobert's type 1 also may present with 2-to-1 AV block. What is not described in the literature is that it requires at least 2 consecutive fixed PR intervals to make the diagnosis. So in summary, Mobert's type 2 AV block is always infranodal and occurs with serious distal conduction tissue disease. And in order, if you just see a 2-to-1 second degree AV block, you cannot make a diagnosis of either Mobert's type 1 or Mobert's type 2 unless you have further information. On a Holter monitor, you would look for evidence of Wenckebach AV block as well. A broad QRS suggests that it might be type 2, but you need more information before making such a diagnosis. So, you need to exclude Wenckebach AV block in all traces. So here I'd just like to summarise again this 2-to-1 second degree AV block conundrum, where it's frequently diagnosed on Holter monitor reports as Mobert's type 2. And you cannot do this unless you have more information and that you've excluded Mobert's type 1. Wenckebach AV block is physiologic at high atrial rates. Here is an example of atrial flutter with 1-to-1 ventricular response close to 300 beats per minute. This is unusual because at a rate of about 200, AV block occurs. And here is what we usually see, atrial flutter with 2-to-1 block and a rate of approximately 150 beats. Always remember that when you see a ventricular rate of 150 beats per minute, it is always atrial flutter with 2-to-1 block until proven otherwise. Now this occurs because the AV node has decremental conduction with block, and at high rates of about 200 will completely block into a 2-to-1 relationship. Whereas Wenckebach block is pathologic at slower atrial rates. Here is an exercise tachycardia and bundle branch block, approximately 110 beats per minute, and you can see here that it's still sinus with a first degree AV block, but there are pauses. And when we put in our red highlight, one can see that these are Wenckebach AV block occurring at a low rate with a bundle branch block that suggests distal disease. Now, Wenckebach second degree AV block isn't completely like I just showed you. About 15% of Wenckebach sequences are typical, maybe less than that. whereas 85 or more % are atypical. The vast majority of atypical sequences are due to heightened vagal tone. So let us have a look at some examples of heightened vagal tone on Holter monitoring. Here is it's usually a nocturnal, exaggerated vagal response. Now the right vagus nerve innervates the sinus node and the left vagus nerve innervates the left sinus node, left AV node via adjacent ganglia. On the ECG, therefore, we see sinus bradycardia as a sign of right vagus nerve innervation, but we can see first degree AV block, second degree AV block, asystole, and ventricular standstill. Here is an example of abrupt sinus slowing overnight, 11:57 p.m. And we can see a classical Wenckebach sequence. But not only that, we can now see the sinus slowing. And this is an extremely common way of demonstrating Wenckebach AV block on Holter monitoring at night. There is a 2.8 second pause. Another one, which is not as common, is that the greatest increase in PR interval occurs prior to the drop beat. And you can see here it is 300 and 580 milliseconds. And it's an abrupt increase in the PR interval before the drop beat. Now this means that the vagus nerve innervating the AV node on the left side has an intense output which puts it just into that PR interval, whereas beforehand it is much less. Here is a junctional escape terminating a Wenckebach AV sequence. Again, a common finding. So one would look at this and say the absolute criteria for Wenckebach are not fulfilled. But this is not so. We can look at this and we know that the reason for it is this junctional escape beat, and therefore we can accept this as a Wenckebach AV sequence. What about high degree AV block? This is a difficult topic, and here we can see a sinus slowing together with 2 drop beats. Otherwise, the fulfillment of Wenckebach is perfect. Now, this is not regarded as Wenckebach AV block by the purist. They call this high degree AV block, because Wenckebach, in his description, only described 1 dropped beat. However, I tend to regard this as an atypical type of Wenckebach AV block. One form of high degree AV block is paroxysmal AV block and continues from what we just showed on the previous slide. This is a situation where there are episodes of ventricular standstill where otherwise the ECG may be completely normal. There are 2 forms, at least, extrinsic and intrinsic. Extrinsic means it's outside the conducting system and is vagal mediated. Intrinsic suggests that there is advanced conduction tissue disease. So now let us have a look at extrinsic. There is no conduction tissue disease. The patient is often young, well, and fit. It is vagal mediated. There is parasympathetic provoking triggers, stress, dehydration, standing for a long time, going to the dentist. There are recognized prodroma. That is the onset of the bradycardia or the ventricular standstill. There's an abdominal sinking feeling nausea, and sweating. And there is a slow sinus rhythm during it with acceleration upon resolution. Now, how do we look at this? Think Wenckebach with higher degrees of AV block, just as I showed you before with the 2 drop beats. And there is usually a narrow QRS. Here is an example of extrinsic paroxysmal AV block. On the top row, one can see the absolute criteria for Wenckebach AV block. Then suddenly there is an abrupt onset of sinus rate slowing and ventricular standstill. And at the end of this, the sinus rate increases upon resumption of conduction and resolution of the heightened vagal tone. Here is another example where we demonstrate progression of the ECG features. Here is Wenckebach AV block, here is 2-to-1 AV block, and then it goes on to ventricular standstill. And again, note that the sinus rate does not change significantly during this, whereas if it was outside the vagal influences, there would be a marked increase in sinus rate. Here is one of interest, which is, I call a blending. That is, there is nocturnal sinus arrest terminating a Wenckebach AV sequence with a long pause. And this would be consistent with condition we call neurocardiogenic syncope, where the patient loses consciousness. But in that situation, we have sinus arrest. But here we also have a blending of Wenckebach AV block with it, and such features are not uncommon. Wenckebach AV block sequences can also occur with non-sinus rhythms. Here is an accelerated ectopic atrial rhythm. Rate is about 88 beats per minute, and you can see the inverted P waves. We now look and see a Wenckebach sequence, an increased PR interval, and then a drop beat, and it reverts to sinus rhythm. So this is a very atypical Wenckebach AV block because we are not in the same rhythm. It's going from an ectopic atrial rhythm to sinus rhythm. Atrial tachycardia frequently has Wenckebach AV block sequences. This is a chaotic looking rhythm and of a rate of about 170 beats per minute. And let us now identify the P waves. And this is an atrial tachycardia. We can see the P waves that conduct, and then there are P waves that do not conduct. And putting this all together, we can see that there are 3-to-2 and 2-to-1 Wenckebach AV block sequences. Atrial flutter presents a very interesting and complicated form of Wenckebach AV block. Here we can see a typical atrial flutter with an irregular ventricular response, and the P waves are approximately 250 beats per minute. The PR intervals, if you follow them, that is the relationship between a P and the QRS, seem to vary. And there are also these variable pauses, some of which are longer, as you can see by the purple arrows, and there are therefore creates sequences between these so-called pauses. Think Wenckebach AV block when you see sequences and most certainly varying PR intervals. So let us reinvestigate this now and look at a sequence. We can see all the P waves, and is there Wenckebach block? Well, If we just look at every alternate P wave, you can see a classical Wenckebach sequence of 3 increasing PR intervals and then a dropped beat. There are therefore in between them non-conducted P waves, alternating. Let's look at the remainder of the tracing, and we can see the conducted P waves as well as non-conducted, and we're now dividing them into sequences, the green and the red highlight. Let's put it all together then, and you can see now between every conducted and non-conducted P wave, there is another non-conducted P wave. And where there is the pause, there are 3 non-conducted P waves. This is a physiologic phenomenon which helps create a rate control with atrial flutter. And it's given the name alternating Wenckebach AV block. It's a multi-level block, and let's now look at this multi-level block called alternating Wenckebach. It's usually called complete heart block. One looks at this ECG and the first diagnosis that comes to mind would be complete AV block. Here we have the P waves and we have a QRS complexes, but what is particularly interesting about these QRS complexes is that they are irregular. And when we see irregularity with what appears to be complete heart block, think Wenckebach AV block. So how do we explain this? Here we have the same tracing, and we have the diagrams here of the A and V conduction, and the impulse comes from the sinus node, goes into the AV node, and every alternate beat is blocked. It's a 2-to-1 AV block. But what about the ones that conduct? The first one conducts with a normal PR interval. The second one conducts with a longer PR interval. And the third one longer again. And not surprisingly, there's the drop beat. And the sequence then starts again. Alternating Wenckebach AV block. And you can see now that there are 2 drop beats, and the so-called 2-to-1 block is supposed to occur after that beat 4 doesn't occur. And this may be a protective mechanism in that the heart doesn't want to go too slow. This is pathological. What I showed you with what I showed you earlier is physiologic, but this appearance may result in ventricular standstill and sudden death. So now look at our atrial flutter with variable AV block, and we can see the 3 consecutive drop beats or non-conducted beats. It's a multi-level block, and it's alternating Wenckebach block. And as I said, it's physiologic and protective. Let us now look at some other examples of Wenckebach block. Particularly, we're looking now at atypical. So a non-conducted atrial ectopic causes confusion. Here we can see a typical Wenckebach AV block, but it's terminated by an atrial ectopic. Here is another one, and you can see here a somewhat complicated 2 atrial ectopics, or are they? Let us have a look at the first, at this ECG, and we can see there the drop beat, and then we have the non-conducted atrial ectopic, which just extends the pause. But an hour before, we have this relationship. Here we've got the sinus rhythm again. We have the Wenckebach AV block. But where is the drop beat? There is here vagal influences, and therefore increased vagal tone slows the heart rate down. And so now the beat occurs there in the middle. And therefore beforehand is the atrial ectopic. So whereas the first one followed the drop beat, the second one is actually before the drop beat and may be responsible for the drop beat itself. Atrial pacing may also give rise to Wenckebach AV block. This is single chamber atrial pacing, and you can see a very typical Wenckebach sequence. This again was in a young person at night and was physiologic. There is a condition called reverse Wenckebach AV block. It's rare, and you can see here that there is sequential shortening of the PR interval with the red highlight. There are no drop beats, but the RR interval is longest with the longest PR interval, and therefore it appears as if there is a drop beat, but this is purely because of a very prolonged PR interval. The irregular RR intervals exclude complete AV block. There are reports of this appearance with AV block and disease in the His-Purkinje system and bundles, and therefore patients have gone on to have pacemaker implantation. What about retrograde Wenckebach VA block? This is usually seen with electrophysiologists investigating tachyarrhythmias at an EP study. It is not seen usually on the surface ECG. But one example is ventricular tachycardia with retrograde 2-to-1 VA block as shown in this illustration. The rhythm is sinus, and there is a non-conducted P wave, or maybe it is conducted with a fusion beat, and then there is ventricular tachycardia, and following each second QRS complex, there is a retrograde P wave seen. Retrograde 2-to-1 VA block. One of the electrocardiograph scenarios where we occasionally see retrograde conduction is with junctional rhythms. Now this ECG is a rather complicated one, but what you see are 5 QRS complexes and a pause. And these are sequences. And when you see sequences, think Wenckebach. So let's have a look at one of those sequences and investigate it further. We can see that there are 2 junctional escape beats that commence the sequence. Both of these have retrograde conduction with RP intervals. Then the first retrograde P wave conducts to the third QRS with a very long PR interval. The second one also conducts to the fourth QRS complex, again with an increasing PR interval. Then we have the third QRS has retrograde conduction, and it goes to just immediately before the fourth QRS, and that conducts as well now to the fifth QRS. And you can see there is a Wenckebach sequence, and not surprising, a dropped retrograde P wave. So this is a junctional rhythm with retrograde 4-to-3 VA Wenckebach sequences. Let us now go beyond the AV node and look at Wenckebach as it appears in other areas of the heart. I stated in my introduction that Wenckebach block can occur anywhere in the heart where myocardial cells conduct. These levels include the sinus node, the atrium, the fascicles, and the ventricles. And how is it recognised? Well, let us go backwards and start at the AV node, and we can see that there is RR shortening, as we said. If in the ventricles it is beyond the AV node, there must be RR shortening as well. And in the fascicles and bundle branches, there's an increasing block. If we go now back to the atria, here we are before the AV node. We cannot have RR shortening, but rather PP shortening, either in the sinus node and atrium. So let us have a look at a number of examples of Wenckebach block beyond the AV node. The first is the well-known type 1 sinoatrial Wenckebach block. Here are the footprints. We can see an increasing P to P interval, decreasing P to P interval, 760, 720, 700 and so forth. And then there is a drop beat. Let's have a look on the ladder diagram, and you can see again there is an increasing block, and as it conducts to the ventricle, in the sinus node, we can see this block of a differential of 40 milliseconds, 20, and then 10. So from 760 to 720, 40 milliseconds, 720 to 700 is 20, and so forth. And then there is a dropped beat. And we don't see it as a P wave because it's within the sinus node. So the PP intervals progressively shorten before the P pause. And interestingly, this shortening continues during the pause, and therefore a pause is less than twice the shortest PR interval, which was 690, and this is now 1360. What about within the atrium? Wenckebach block occurs at the ectopic atrial interface. That is, we have an ectopic focus firing off, and there can be a Wenckebach block there. Here we can see an example of what we call a non-conducted focal atrial tachycardia. And this very frequently shows such Wenckebach phenomenon. There are the sinus beats, and then we have the non-conducted focal atrial tachycardia, and you can see straight away that there is shortening of the P to P intervals. Then follows a sinus pause after termination of the tachyarrhythmia. Let's have a look at it with the ladder diagram, and we can now see an example where at the ectopic focus it fires off regularly, but at the ectopic atrial junction there is an increasing block so that the P to P intervals shorten until the drop beat. What about fascicular Wenckebach block? It may occur in the right bundle branch or in the separate fascicles of the left bundle branch. Having a look at this ECG, it looks like typical chaos. Can we make sense of this? So let us just take V1 and have a look at the ECG, and we can see that there is sinus rhythm present, and V1, there are inverted P waves. And then there are three types of QRS complexes. There's the first one, which is 90 milliseconds. The second one, which is slightly broader, at 110 milliseconds. And the third one is 140 milliseconds, which is a complete AV block. So we have normal conduction, complete block, and in between a lesser degree of block. And this is a Wenckebach sequence in the fascicles. As I said, it's been reported in both the right bundle and in separate fascicles of the left bundle. Such an appearance can occur with a multi-level block. You remember we talked about multi-level blocks with alternate Wenckebach AV block. Here is another multi-level block. Have a look at the first two QRS complexes, yellow highlight and blue highlight, and they are different. The first is narrow and the second is wide. Then follows a Wenckebach sequence. That is 3 increasing PR intervals and a drop beat. But what is particularly interesting is that at each level, the QRS widens as well. 100 milliseconds, 160 milliseconds, and 180 milliseconds. This suggests that there are 2 blocks. There is a Wenckebach AV block at the AV node, but there is also an ongoing block in the fascicles below it. Wenckebach block can also occur at the ectopic ventricular interface. Here we have a run of ventricular tachycardia, a focal focus where it's firing off. And we can see that there are pauses. And as well as that, there is shortening of the R to R intervals. And immediately we think that this is a Wenckebach block beyond the AV node. So let us have a look at the ladder diagram, and you can see that in following the drop beat, there are 3 beats with a delay occurring at the ectopic ventricular junction before conducting to the ventricle, and then there is the drop beat. Wenckebach AV block can also occur with ventricular pacing, and it occurs with the dying heart. Here is a patient who immediately before dying has this pacemaker ventricular block. You can see that there is the stimulus artifact. There is a latency period where it takes time to depolarize the ventricle, and it does this in a Wenckebach fashion, increasing the block until there is failure of pacing. And then the sequence starts again, but now with a 2-to-1. So in summary of this one, you can see that we have latency, that we have second-degree AV block, and finally, of course, third-degree AV block, where there is complete failure of ventricular pacing. So what have I learnt? Wenckebach block can occur at any level in the heart. Wenckebach block, AV block, is most common in the young and is due to heightened vagal tone. There are 3 absolute footprints of Wenckebach AV block, the PR interval longest immediately before the drop beat. There are non-conducted P wave, and the PR interval is shortest immediately after the drop beat. And then most Wenckebach AV sequences are atypical. Thank you for listening, and if we have any questions, I will answer them now. For those who are interested, more information can be obtained from Harry's Corner at Cardioscan, and if you would wish to contact me directly, there is my email address as well. Thank you for watching. At the moment, we have a few questions, but they were presented early in my talk, and I have covered them. This included sinoatrial Wenckebach and reverse Wenckebach. One of my slides, I talked about VA Wenckebach, and I must say that I've actually made an error here. This wasn't VA, it was AV, but this slide actually did show VA Wenckebach as well. I will be covering this topic in the next few weeks with my What Do You Think presentations that I send out each week. The next webinar will be a topic on the technological evolution of cardiac pacing and memories from a bygone era. This is not ECGs, but rather will be a historical lecture because these lectures have not been presented generally and are being lost now. We plan a tentative date on the 22nd of August. We'd like you to fill out the survey at the end of the webinar. And once again, thank you, all the attendees who have joined us today, and we look forward to seeing you at the next one.